Good evening, respected professor, my dear students. I welcome you all to the second session of this new year. Today we have an interesting session on practical aspects like ICG, PFT, and ABG. Without wasting much of your time, I hand over the session to professor and the students. Over to professor and students.
Okay. So we'll start with ABG. The plan is today we'll try to cover ABG, PFT, and some X-rays, time permits. Before we go to solve the problem or interpret the ABGs, we'll just go through some basic things we have to know about ABG, like in the question answer format. And after completing that, we will go for the interpretation or problem solving ABGs. Okay. So I'll straight away go to share my screen with you. So is my screen visible?
Yes, sir.
So, now what are you seeing here? I'm showing you two pictures here. So what are being shown here?
The derived values and calculated values of ABG in first picture.
See? This is a very detailed report on ABG. Okay with that?
Yes, sir.
You have not only the basic parameters, but also you have the detailed A gradient, gradient, and so many things, maybe are small, everything is given. So this is a more detailed ABG report, and this you can call it as a abridged report, okay, or a short form where you require only the basic things. And so this is a detailed ABG report, and then abridged quick reference ABG report on the right side. This is on the left side. Now, what is the first step in the ABG interpretation? Whenever you are given a report like this in your hand in the examination, how will you start the ABG interpretation?
Look at pH, PCO2, and bicarbonate.
Okay.
Patient, correct patient.
First, whether it is acidosis or alkalosis, then whether it is respiratory or metabolic, then compensated or non-compensated, like that.
Okay.
Whether the
Okay.
patient taking with any FiO2 or room air.
Okay.
And temperature that written in there.
Okay. If you see these two reports, what is the first thing you see here?
Patient identification, sir.
This is the one you should always start with. In the exam, the examiners expect you to say this first. I'll make sure whether it is an X-ray or whether it is a PFT or whether it is an ABG. The first answer that is expected out of you in the practical exam is, I will confirm that this is the patient whom I'm going to see the ABG report of. So I will check and verify the identifications of the patient. Make sure that I am reading the correct X-ray or correct ABG or correct PFT. Here also you can see this is an arterial sample, system name, system ID, patient ID. The first thing what is given here is only about patient demographics. Okay. So this is what the examiners want you to say in the exam, so that you don't mistake if somebody else's report as a report of a patient who is really sick or ill. Okay? So that is the answer that is expected. Of course, it is practically also very important that whenever you see an X-ray or an ECG or a PFT or ABG, always make sure that you are looking at the correct report of the correct patient. Okay? After that only you go to analyze whether it is acidosis, alkalosis, compensated, uncompensated, whether there is an anion, gap, high anion, normal anion. All those things come later. Okay, so don't forget this point. If they ask you what is the first step, always make sure to say that I will check and verify the patient details or identification. That is the first answer that you have to give. Why electrolyte values are given in this ABG? You can see both in the abridged version as well as in the detailed version. You have all the electrolyte values given. Okay? So sodium, potassium, calcium, chloride, everything is there. So what is the importance of that electrolytes being given in the ABG report?
Calculate the anion gap, sir.
Anion gap, yes, it is given to calculate the anion gap. That is a very, very important point that is must know that it is all given usually along with there. Not only the PO2, PCO2 bicarb, but also the electrolytes are given to calculate or help you to calculate the anion gap. Okay. Now, what is blood gas analysis? Which blood is to be used for analysis? What is the definition of blood gas analysis?
ABG is arterial blood gas analysis and VBG is venous blood, sir.
Yeah, but what does that mean? What are you analyzing?
To
Self-explanatory.
evaluate the patient's oxygenation or
Gas levels. Okay.
Yes.
So you can say blood gas is a diagnostic tool to evaluate the partial pressures of gases in the blood and acid-base content of the blood. Okay. So the blood gas analysis we do for diagnosing some conditions. So it's a diagnostic tool to evaluate the partial pressure of oxygen and carbon dioxide and also the acid-base content of the blood. And we can do that with blood obtained from anywhere in the circulatory system, namely artery, vein, or even a capillary blood analysis can be done. Okay. I'm not specifically saying arterial blood gas. So it is saying only blood gas analysis. So blood can be taken from anywhere in the circulatory system. What does arterial blood gas analysis estimate? So now that we have seen that we can take the blood from anywhere, artery, vein, or capillary, why specifically we always go for arterial blood gas analysis?
More accurately determine the oxygenation of the patient.
Okay. So that is the one which is estimates the PaO2, which gives the oxygenation status, and the PaCO2, which indicates the status of ventilation. So the ABG only will give you both these values, because if you take a venous sample, already the oxygen has been extracted from that. So the PO2 will be low. So you cannot correctly estimate the oxygenation status. And similarly, PCO2 may be high in a venous blood. So arterial blood gives you the correct status of oxygenation as well as ventilation, because if PaCO2 is normal, ventilation is adequate. If PaO2 is normal, oxygenation is adequate. Okay, so that is the reason why we always insist on arterial blood gas rather than venous or capillary blood gas. Can oxygenation and ventilation be estimated non-invasively? Which is the gold standard to estimate? How are you doing your estimations in the OT when you are anesthetizing a patient? How do you say that?
SPO2,
N-tidal
SPO2 and ETO2.
SPO2 and ETCO2.
ETCO2.
Non-invasive methods are about 2 parameters by pulse oximetry and ETCO2. These are the indirect or non-invasive methods of measuring the oxygenation as well as the ventilation. Okay, but ABG is the gold standard of estimation of oxygenation and ventilation. Okay, who invented the blood gas apparatus? Supposing you perform very well in the exam, the examiners always try to see whether you have some knowledge about the history or the inventors to give you more marks. It is always better to know some names so that you get the best mark in your exams. No idea? At least
No
one
idea.
in the country where person originated.
India, sir.
I'm sorry, not India. Okay. John Wendell Severinghast, who made the CO2 electrode, is the inventor of blood gas apparatus in collaboration with a company. It's a Swedish company, Danish company, or a Swedish company called Astrup. So this originally, when the blood gas machine came to Stanley, when we were working there, the first blood gas machine in the government setup was available only in Stanley in the anesthesia department. So in 1983, my chief got this instrument. Because the company which manufactured this called Astrup, we used to call this Astrup machine only. We never used to call it as blood gas machine. So Astrup became synonymous with blood gas. And it was John Wendell Severinghast. So we have a Severinghast electrode which helps to estimate the CO2 level. What is the electrode used to estimate the oxygen level? These are all sometimes asked as short notes in theory. For those who are going to appear for theory exam, they may ask you in theory also the methods of estimating oxygen. Clark's electrode. Have you not heard of that word? Clark. So, who introduced the concept of pH and why did he introduce it? This is another basic question you can expect in the examination. Somebody knows that? Sorensen. Okay, Soren Peter Lauritz Sorensen is the full name. He is a Danish chemist. He is not a doctor. He is a chemistry fellow. And he introduced the concept of pH for measuring acidity and alkalinity. All of you know that when we read chemistry, high schools, we did experiments to find out whether a substance is acidic or alkaline by doing the test in the lab. So in chemistry, he introduced the concept of pH. Okay, for measuring the acidity and alkalinity, and it is not by any doctor or anything. So Sorensen is the person. He's a Danish fellow from Denmark. Okay, who introduced the technique of CO2 measurement. Already I asked you that question. Just now told the name.
Clark.
Leland C. Clark Jr., an American biochemist born in Rochester, New York, introduced an electrode to measure CO2. Okay, so it is called Clark's electrode, Severinghast electrode for CO2. These are the only two things which are actually measured by the blood gas machine. All the rest are all, and pH of course is also measured. So these three parameters are only actually measured. All the other things are extrapolated from that. Even your bicarb is not actually measured. So remember that blood gas machine actually measures and gives you the value of pH, PCO2 and PO2. Okay. So these are some of the points you have to keep in your mind before you go into the exam. What are the components of ABG report? And name them. I have already told you the answer.
The pH, the first will be the demographics, then the values, like that's what we'll have to tell.
The components can be classified as measured components and calculated components.
Calculate.
Okay? So ABG components are classified into measured. So the measured values are pH, PaCO2 and PO2. Calculated values are bicarb, SaO2, base excess or deficit. And what does pH stand for? What is the expansion or what is the acronym? expansion of the acronym pH. Why this P is written as small and H is capital?
H is for hydrogen ion, sir.
H is for hydrogen. What does the P stand for? Did not expect these questions. I am very quite surprised, isn't it? I thought straight away we will be asking about whether alkali or acidic or alkalic pH or whether it is PSO to normal. These are some of the basic things you have to remember. The full form is power of hydrogen in English. Okay, pH stands for power of hydrogen in English language, but originally the person I told you is a Danish person, Sorensen. So he gave the Danish name or Danish language. The power is called puissance. So puissance hydrogen is the exact word which it is also for like a French word is what he used. I mean, and the potence hydrogen is the Danish word he used, and then French people called it as puissance hydrogen, and Germans called it as potency or potence. So the English expansion for pH is power of hydrogen. In French it is puissance, in German potence, and in Dane it is potence. Okay? So that is the short form, because hydrogen ion forms the main component for the changing or measuring your pH. So which pathological conditions require ABG analysis?
Hypoxic conditions.
Hmm.
Sepsis.
COPD, respiratory.
We already told in the previous slide, two things we measure by using arterial blood gas analysis are oxygenation and ventilation. Oxygenation means delivering oxygen to the mitochondria. Ventilation means eliminating the carbon dioxide produced by aerobic respiration. These are the two fundamental things. So your ABG is indicated whenever you suspect oxygenation is not all right, or elimination of carbon dioxide and ventilation is not normal. Isn't it? That is the basic thing. So pathological conditions in which ABG is useful: respiratory diseases resulting in inadequate oxygenation and CO2 elimination, or it can be metabolic disorders causing acid-base disturbance. So instead of saying individual conditions, can grossly classify them into respiratory or metabolic conditions are the indications for ABG analysis. What is the common process for taking the arterial blood sample? What are all the steps? I hope all of you had the experience or been trained in taking a blood gas sample, isn't it?
Yes.
So how do you do that? Tell me the steps of taking an arterial blood sample from a patient.
Before we should do Allen's test to
We should first inform
modify
the
Allen's
consent from the
First,
First
we have
of
to
all, you must
explain the
say which
process to
artery
the
you want to
patient.
select, isn't it? You can take arterial blood gas from any artery, even the aorta you can take. But
Yes.
where do you normally take the blood from?
Radial artery.
Radial artery. Okay, so you must take collection of blood sample process, usually from radial or femoral. What are the indications for taking it from femoral?
Surgery.
So the BP is too low, we'll not be able to feel the radial artery, so we'll end up pricking the femoral.
Very good, very good. Okay. Any other indication? Any patient group?
Peripheral vascular disease, sir.
Sir, dialysis patients who have to,
Fistula.
we have to preserve that radial artery. For
Very small kids, pediatric patients, which is easier, femoral or radial?
Femoral.
Femoral. Okay, so pediatric age group, usually, especially in emergency, we don't struggle with the small radial pulse. We go for the femoral pulse, femoral artery. So first identify which vessel we are going to take from, number one. Then we must take a small size syringe. You should not take a 10 ml or a 20 ml syringe. Okay, you must, which is the ideal syringe, 2 ml or 5 ml or 1 ml?
2 ml, sir.
2 ml is ideal because that is the you can hold it comfortably, and also what is the advantage of taking a small syringe? What
Lesser
error you can avoid? Larger the syringe, which will be more, the space inside the syringe is more. So what can, what error?
Air,
Air bubble entrapment can happen with a larger syringe. Okay, smaller syringe is due to prevent that problem. And glass is preferred over plastic. Of course, nowadays you don't get glass syringes at all. But why glass syringe is preferred over plastic? Think it over and tell me before the end of the class. Specimen syringe to be placed in ice if there is a likely to be a time delay in analyzing the sample that we have taken. That is another thing. So we must keep ice packs, everything ready. If you are not going to analyze it, then how much? What is the time limit before which at room temperature you can keep it and analyze?
20 minutes. 20 minutes less.
20 minutes. Very good. So air bubble to be avoided. What errors can happen if air bubble enters and there is a delay? So what is the error in the result you will get if there is an air bubble entrapment in the sample, or if there is a delay of more than 20 minutes, the sample has been kept in room air, what wrong values you may get in the report?
due to metabolism, the oxygen will be utilized and there will be lesser value.
Where? In the
pH,
bubbles or
When
the
it is more than 20 minutes. And if there
20
is air
minutes,
bubble,
if there's a delay, yes, you must be
if there's
specific
delay.
in your answer in the examination. If there is a delay, there will be a low PO2. If there is a
Yes.
air bubble,
It will be more, sir. The CO2 will be
oxygenation
more.
will be more, but CO2,
CO2 will be less, sir.
okay, so the CO2 will fall. Okay, so air bubble enters the syringe, CO2 will increase, will be not normal as exactly in the patient. It will show a higher value, and PCO2 value will be lower because oxygen will diffuse out of the blood into the water or in the air bubble. So there will be low PCO2, and if there is a delay, as you rightly said, the cells in the blood sample will utilize the oxygen, so PO2 will be lower than the actual value. So these are the two errors that can happen. And you must specifically say which one is which one. So delay in analyzing in room temperature, PO2 will fall. Air bubble entrapment, PO2 will be higher and PCO2 will be lower. What is the normal range of pH, PaCO2 and PaO2? Values you are all
pH 7.35 to
7.45.
very good.
pH
CO2 is from
why this
35 to
mid
45.
value? Why this mid value of 7.4 is important? Because sometimes when there is, even though we say this is the normal range, sometimes during calculation we may have to take a value less than 7.4 as acidic and value more than 7.4 but below 7.5 also as basic. Okay, so that is the reason why this value is important. And PaCO2, of course, you know 35 to 45. Above 45 it is acidic and below 35 it is base. And PaO2 75 to 100. So how to calculate the arterial oxygen content?
It is a sum of the dissolved oxygen and that which is bound to hemoglobin, sir.
So what is the formula?
1.33 into
So there are two components as rightly said. One is the dissolved oxygen, another is the oxygen carried by the hemoglobin. Okay.
1.34.
The dissolved is calculated using the partial pressure. This is where your ABG value is important. So PaO2 multiplied by 0.003 is the dissolved oxygen in plasma. and saturation SaO2 multiplied by 1.3 multiplied by the hemoglobin value gives the oxygen carried by that. So both added together, you get the oxygen content. This is a very important formula. All of you should know by heart. No mistakes will be permitted in the exam. So this is a very, very basic thing you have to by heart and keep it always ready in mathematics. What are the normal and standard bicarb values? What is the base excess or deficit? What is the difference between normal bicarb and standard bicarb? Many ABG reports will give these two values. One it will say bicarb, another below that it will give STD bicarb.
So bicarb is 22 plus minus 2.
No, what you measure is the normal bicarb. Okay,
Yes, sir.
22 to
Yes.
26. But what is standard bicarb?
Calculated, sir.
Calculated. When you standardize the condition, you get the different value. Okay, so normal bicarb is what you measure actually in a patient who may be having a temperature, who may be hyperventilating, or who may be in severe acidosis. So that is the actual or normal measured bicarb, whereas this is the standard bicarb but standard condition. Okay, so bicarb 22 to 26, the mid value of 24 is the normal bicarb. Standard bicarb is 21 to 27 with a PaCO2 of 40 and temperature of 37. So when you standardize these two things, the irrespective of patient may be in alkalosis, respiratory alkalosis or acidosis, but when you standardize the value of the PaCO2 and temperature to the normal values, what you get is called the standard bicarb. And the base excess or deficit is the difference between the actual and the standard bicarb. That is how you calculate the base excess or deficit. Whenever there is less, you give a minus value, which is called the deficit. Whenever there is a excess, it is called the plus value. Okay. How to calculate the total carbon dioxide? And what is the normal oxygen saturation? Arterial oxygen saturation.
95 to 99.
95 to
99.
99 is saturation.
Yes, sir.
Total carbon dioxide, how do you calculate? Again and again, we have to always remember that ABG estimates the oxygenation and ventilation. So we have to know these values. So total carbon dioxide can be calculated by the bicarb plus A into PaCO2. A is the standard value of 0.226 millimoles per kilopascal. Multiplied by the PaCO2 value to get the total carbon dioxide is normally about 23 to 30 millimoles per liter. Okay? And SaO2 is usually 95 to 100%. What comparison, gradient and ratio to be checked during ABG? What are the things you compare? What is the gradient you look for? And what is the ratio you have to check during using the ABG?
Alveolar and arterial gradient.
Arterial gradient, very good, excellent.
PaO to FiO2 ratio.
Total ratio.
Yes, FiO2 ratio, very good. Comparison,
Is it ABG, sir?
so you compare the PaO2 versus SpO2.
SpO2.
Okay, you get the alveolar arterial gradient, get a PaO2 FiO2 ratio. Okay, so these are the three things we always look for in the APG. What compensation rules are used when you look at an ABG report? Find out whether it is a compensated state or an uncompensated state. In which conditions you have to apply compensation rules? There are only two conditions in respiratory, metabolic. Respiratory, what do you have?
Metabolic.
Acidosis,
Acidosis,
alkalosis.
alkalosis. And respiratory acidosis and alkalosis can be acute or chronic. Whereas in metabolic, you get only acidosis and alkalosis. There is no acute or chronic in metabolic. Okay. So these 6 conditions you have to apply compensation rules. Okay. So you can see compensation rules for metabolic acidosis. In acidosis, what happens? Bicarb is the main thing which is affected. It will be reduced, isn't it? Whenever you have metabolic acidosis, you have low values for bicarbonate and you have high values for bicarbonate in alkalosis, metabolic alkalosis. So the compensation has to come from the form of PCO2. Whether the body wants to eliminate PCO2 in acidosis, retain PCO2 in alkalosis. So the compensation will be applied only to find out whether the measured PCO2 value equals the compensation that should have happened in the patient. Okay. So bicarb, whenever it is affected, look for the PCO2 value, which is applied only to metabolic changes. Whereas in respiratory, there is an acute change and a chronic change. A COPD patient will get a lot of adaptations in the body. So in respiratory acidosis, we want to find out whether the bicarb is compensating for the change in the acid base status. So you have to calculate the expected bicarbonate in respiratory conditions. So both respiratory acidosis and alkalosis, there are acute and chronic stage. So to find out the expected bicarb value, you have to use the compensation formula. Okay. So there are 1, 2, 3, 4, 5, 6 formulae or compensations that we have to use. So for metabolic, we have to always find out the PCO2 value. For respiratory changes, we have to find the compensated bicarb value. As simple as that. Is it clear?
Yes, sir.
Now, what is gap-gap ratio? What is the other name for this and what is it used for? Some silence. Never expected this.
Sir, I think it is anion gap and delta gap ratio. something like that.
Exactly. Gap is another name for delta gap. So the ratio between change in anion gap and change in bicarb value is called the gap ratio. It is also called the delta gap. It is used to identify complex disorders. There's another question to show what is a simple disorder and a complex or a combined disorders. Okay. So gap ratio is change in the anion gap to the change in bicarbonate value. Normal anion gap, the measured anion gap minus 12. This is the normal value of anion gap 12. So whatever the anion gap that you measure with the electrolytes, you subtract the normal value. Similarly, you take the normal bicarb value and subtract the measured bicarb value, then you get the changes that is happening. So the calculations, it is mainly only in metabolic acidosis. This anion gap, please remember, it is not useful in alkalosis. It is useful to find out whether it is a associated alkalosis, but not in pure alkalosis. So metabolic acidosis conditions, we have to use this anion gap or the delta gap. So if the value of that delta gap is less than 0.4, this ratio, then it is a low or normal anion gap metabolic acidosis. When the value is between 0.4 and 0.8, it is normal plus high anion gap metabolic acidosis. If it is 0.8 to 2, it is pure high metabolic acidosis. And if it is more than 2, it is metabolic acidosis with metabolic alkalosis or respiratory acidosis. So the combined disorders or complex disorders are made out only when you know how to use this delta gap or gap. Otherwise, using the simple formula of finding it whether it is less than 7.35 pH or more than 7.45, you can simply say it is only acidosis or alkalosis. But when complex or combined disorders are present, that can be calculated only using these formula. Without that, it will not be easy to do that. Okay. How to calculate sodium for anion gap in hyperglycemia? Sodium values are likely to be abnormal in patients with hyperglycemia. So can you straight away take that value and calculate the anion gap, or do you have to calculate the correct sodium value if there is a hyperglycemic state in diabetic ketoacidosis and other conditions?
Corrected value has to be taken, sir, but I've forgotten how.
So how to correct that? What is the corrected value? So corrected sodium for AG in hyperglycemia is sodium that is actually measured plus glucose minus 5/3. Okay, then only you get the corrected sodium value for that condition. Otherwise, you will be having a lot of low sodium value, which will not give you the correct picture of gap or the delta.
Sir, that is glucose in millimole per liter only, no, sir?
Millimoles per liter.
Okay, sir.
Not in milligram. Okay. And range of parameters, these are the range. So pH more than 7.45, we have alkalemia. 7.36 to 7.44 is normal. So all these values, all of you are well versed with. And lactate is very, very important. Less than 1.9 is normal, more than 2 is high lactate. Similarly, PO2 80 to 100, less than 80 is hypoxia. Okay, so these are some of the normal range of parameters. When does alveolar oxygen gradient increase? In which condition you will have the alveolar to arterial oxygen gradient? What is the normal alveolar arterial oxygen gradient? How many millimeters of mercury? These are all basic respiratory physiology questions. You should not take this much time to answer this. Okay. This increases in lung parenchymal diseases. Normally, it is less than 5 to 10 millimeters of mercury. Okay. Alveolar oxygen will be almost 100 because from the atmospheric air, when it comes down, it comes to almost 100 millimeters of mercury, and the venous oxygen blood that is coming there, even though we call it as artery, it is the pulmonary arterial blood that is quite low. So that, the arterial blood which gets oxygenated is almost 95 to 100. So there is a very little gradient between these two. But in parenchymal diseases, this will be grossly affected, and that can be detected only by which test? Which pulmonary function test will tell you this change in the AO2 gradient?
DCLO, sir?
DLCO or TLCO. Okay. That we will see when we see for the pulmonary function test. What are the first and second line of buffer systems in the body? How do they work to maintain the pH?
Buffer and
very
phosphate.
good. First line is bicarb and proteins. Second line is
chloride.
Phosphate and hemoglobin.
You can divide that into first line is chemical buffer, which is bicarbonate, phosphate, and protein. And second line is physiological buffers produced by respiratory compensation, which comes quite early, and then later renal mechanisms. Okay, so these are the buffer systems. So these are all basic theory parts which you should be aware of. So don't think that once they give you the ABG report, they will ask you only about the diagnosis, whether you are diagnosing respiratory acidosis or metabolic acidosis. Suddenly, all the questions may go to the basic physiology and they can ask you all these things. So be prepared for that. That is the reason why, even though you may find it boring, I am giving you all the details. So the respiratory compensation comes faster, more than the renal compensation. So whenever there is a increase in hydrogen ion causing metabolic acidosis, PaCO2 will be washed out. So PaCO2 will come down. You can see the arrow going down. Alveolar ventilation increases. When you have metabolic alkalosis in the form of this is reverse. This is metabolic acidosis where PaCO2 will have to be, sorry, the arrows are not correct. So whenever the, this is correct. This is acidosis where hydrogen ions increase, PaCO2 goes down. When there is alkalosis, there is an increase or retention of PaCO2 to bring back the pH to normal. So that is the opposite movement that is happening. What is the importance of Henderson-Hasselbalch equation? How can you write the equation? Sometimes exams they give you a paper and pen and ask you to write the equations also. This is the importance of Henderson-Hasselbalch equation. What does it compare?
pH and the pKa, sir.
It is the relationship between pH, bicarb and PCO2. Okay, correlates metabolic and respiratory regulation. So in pH, pK log by bicarb and PaCO2. Simplified, pH is equal to bicarb by PaCO2. So this is the importance of this equation is to correlate the changes or the responses between metabolic and respiratory regulation. How soon the buffer systems come into play? I told you earlier, bicarbonate buffer system acts in few seconds. Respiratory regulation starts within minutes. So this is within seconds, this is within minutes, and you get the maximum response within 2 hours and complete response in 12 to 24 hours. Renal regulation or renal buffering system starts only after a few hours, but has a prolonged effect of up to 5 to 7 days. Okay, so these are the 3 important mechanisms which help to maintain our pH within normal limits. What is a simple acid-base disorder? Earlier we saw complex disorders. So what should be a simple acid-base disorder? Supposing I tell you the pH is 7.21, what will you say for the
Acid.
Acidosis.
acidosis or acidemia? And if the pH is 7.51, what will you say?
Alkalosis.
Alkalosis. So we do not know whether it is respiratory or metabolic, but we say it is acidosis or alkalosis based on the pH. Okay. So a simple acid-base disorder is a simple primary process of acidosis or alkalosis with or without compensation. That is the definition of a simple acid-base disorder. What are the characteristics of simple acid-base disorders? Whenever you have that, you can have the hydrogen ion level, pH and bicarb. Okay, so these are the changes that are going to primary responses that will happen, and the compensation has to come in the form of altering the PaCO2 value in a metabolic conditions and bicarbonate value in conditions of respiratory disorders. So that is what we saw in the earlier slide also. So please remember the compensation. In metabolic conditions, it is the PaCO2 or the carbon dioxide which is going to compensate, and in respiratory condition, it is the bicarb which is going to do the compensation. Okay, so that is the characteristic. What are the compensatory responses? You can see again, these are all the changes that will happen. In acute respiratory acidosis, because CO2 is accumulating, bicarb has to increase to bring the pH back to normal, because whenever CO2 is retained, it will mix with water and become an acid, like a carbonic acid. So to compensate that acid, bicarbonate has to increase in our body. So in acute condition, there will be an increase of 1 milliequivalent of bicarbonate for every 10 mm rise in PCO2. Whereas in chronic condition, there is enough time, so body retains more bicarbonate. So 3.5 milliequivalents will rise for every 10 mm. Similarly, in alkalosis, the bicarb has to go down. Otherwise, if the bicarb also increases, it will produce both metabolic and respiratory alkalosis. So the in compensation for respiratory alkalosis should be a decrease in bicarb, and that is done by decreasing 2 milliequivalents for every 10 mm and 5 milliequivalents for 10 mm in chronic conditions. Very easy to remember that. And in metabolic acidosis, always the compensation is by carbon dioxide. So in metabolic acidosis, carbon dioxide will be washed out. Patient will be hyperventilating, and they will remove the carbon dioxide. 1.3 mm will for every decrease in 1 millicurrent of bicarbonate, or the limit of CO2 is maximum 10 millimeter rise. Similarly, PCO alkalosis, the PCO2 has to be retained to bring back the pH to normal. So this is the change that will happen. So that is remembered by a mnemonic called 1245 mnemonic in respiratory disorders. So you can see here in respiratory acidosis, the change is 1 milliequivalent in acute condition. This 3.5 you can remember as 4 milliequivalents in chronic conditions. Whereas in alkalosis, the change in bicarb, decrease in bicarb is 2 milliequivalents in acute condition and 5 milliequivalents in chronic condition. So the first 1 and 4 are for the increase in bicarb in acute and chronic respiratory acidosis. And the 2 and 5 are the decrease in bicarb in acute and chronic alkalosis. And if you add the 3 here, you can remember HCO3, that is the bicarb. So that can be incorporated. And you can remember that 1, 4, 3, 2, 5. If you remember that way, it will be easy. That is 1 and 4 will be the change in the bicarbonate in acidosis, acute and chronic. And 3 is the indicator of bicarb. And 2 and 5 will be the change in bicarbonate or decrease in bicarbonate in acute and chronic alkalosis. So this is the mnemonic to remember that, so that you can easily work out the compensation that is there. What is Winter's formula and where is it used?
So, it is the compensation of carbon dioxide to change in bicarbonate.
Metabolic condition. Okay, right. Winter's formula is to find out the expected PCO2 in metabolic conditions, whether it is acidosis or alkalosis. So the formula is expected PCO2, which is equal to 1.5 times the measured bicarbonate plus 8 plus or minus 2. Okay, so that is the Winter's formula. It is used to calculate the expected PCO2 in metabolic acidosis mainly. And what is modified Henderson equation and where is it used? Earlier we saw the Henderson-Hasselbalch equation, which says pH is equal to bicarb by CO2, the simplified form. What is a modified Henderson equation and where is it used? Idea? Okay. So it is the hydrogen ion concentration is equal to 24 multiplied by PaCO2 by bicarbonate. So if you, this equation is used to assess what is called the internal consistency of the ABG report. So whenever you get an ABG report, to find out whether it is the correct sample from the artery and that has been taken correctly and measured correctly, you must always see whether the report is reliable or not. That is called the internal consistency of the ABG report. That you can calculate by using this formula. So how does pH correlates with hydrogen level? When you have a pH of 7.4, which is considered normal, what is the hydrogen ion level in that?
Inverse
No
relation.
confusion? Huh?
Inverse relationship, sir.
Inverse, what is, I am specifically asking for 7.4 pH, what is the hydrogen ion concentration in the blood?
Okay.
How can you write 7.4 as, if you want to put two decimals, how will you write that?
7.4 into 74.
7.40, isn't it? You will write it as 7.40 because your normal range is 7.35 to 7.45. Okay, so 7.5 for practical reasons is all 7.40. Okay, so pH or the hydrogen ion concentration is calculated by 24 multiplied by CO2 by HO3. So the pH must be converted to hydrogen milliequivalent. For 7.4, the hydrogen will be 40. Okay, so if you take this formula, 24 is the normal backup, CO2 is 40 normal, even though you have 35 to 45, and the middle value of bicarb is 24. So if you cross both these things, you get 40. Okay, so for a pH of 7.4, if you get a value out of this equation as 40, that means it is a correct sample and correct calculation. That is, that indicates the correct value of your blood gas sample, and you can go ahead to interpret that. So this is a very important thing, pH versus hydrogen ion concentration. At a 7.4, you have 40. As the pH goes down, 7.3, 7.2, the hydrogen ion has to increase. So for every 0.1 decrease, you can see it decreases, this increases by 10, then 14, then 20. At 7, it is 100 millimoles. And if it is increasing pH, the hydrogen ion goes on decreasing. Okay, so the last two digits will be the equivalent of the hydrogen ion concentration in normal range. So hydrogen ion is equal to 80 minus decimal digit of the pH is the easy way to calculate the hydrogen ion concentration. Okay, so that is how you calculate the hydrogen ion and look for the internal consistency. Now the 6 steps before you start interpreting the ABG. First one is the ABG authentic. That is the calculating the internal consistency. Then step 1 is to, and also before that you look for the demographics or the details of the patient. That can be taken as the first step. Then if the ABG correctly taken, then you calculate whether there is acidemia or alkalemia, and then look whether it is respiratory or metabolic. And if respiratory, find out whether it is acute or chronic by using the compensation formula. Is there a compensation which is adequate or not? And if it is metabolic, look for the anion gap, because only in metabolic conditions this becomes useful. And if it is a high metabolic acidosis, look for the gap or the delta gap. So if you remember these steps, you can easily do the interpretation in a orderly manner and come to the full diagnosis. So the example here is, there is a pH is 7.18. So it naturally indicates that it is acidemia or acidosis. What is the difference between acidemia and acidosis? Both are different, or it is interchangeably correctly can be used?
Sir, acidemia is the process of acidosis. Acidosis is, and acidemia is increase in the H plus in the blood, where acidosis is not necessary to increase in the H plus ion in the blood.
I showed it earlier in one of the ASCII slides last previous week. Right, okay.
Acidosis is in tissue
low
level.
here.
Acidemia.
The blood level. Okay, so that is how I defined that in the last ASCII class. So please go through that, you will remember that better. And so the step one is this acidemia. The pH is low. Look at the PCO2. That is also low. Okay. So there is a washout of carbon dioxide. So it is primarily a metabolic phenomena. So you can say it is a metabolic acidosis, where CO2 is compensating by getting washed out. And the PCO2 expected to go to that level. So 1.5 multiplied by bicarbonate, 8 plus or minus 2. So you get this value of 17.7 or I mean 21.7. This is the range. So it almost matches. That means PCO2 compensation is good in this case or correct. And step 5, because it is metabolic acidosis, look at the anion gap. You go through the calculations and you get a value of 30.8, which is quite high. So the anion gap is 36. Normally it is only 12. So it is almost 3 times more than normal. So it is a high anion gap metabolic acidosis with a respiratory compensation. Is it fully compensated or not? Now in this example, I showed you the steps how to go ahead and interpret. Now the question the examiner may ask you, or as an examiner I am asking you, is a fully compensated state because PCO2 is matching the expected compensation.
No, sir, but the pHs isn't written to normal.
That is the most important thing. So this is still a partially compensated. So to bring only when the pH comes back within the normal range and the PCO2 is washed out or reduced, then you can call it as a fully compensated metabolic acidosis with a high anion gap. Otherwise, if the pH is still low or on the alkaline side in the condition, it should always be called as partially compensated in the examination, which you will see in the ensuing slide. So, do you find any step missing in the above two?
So gap has not been calculated.
Gap has not been calculated. But very good.
Authenticity of the ABG.
And the first one, as I told you, you always identify the
Demographics.
patient demographic details. Okay, that is also missing. Now, what is done here and what is the purpose of doing this?
Modified
Allen's test.
Modified Allen's test. What is the purpose of doing that?
to check the patency
Check for adequate.
Compensatory or the collateral blood flow through the radial artery. I mean the ulnar artery. So whenever you want to take a radial artery blood sample, you must always do the Allen's test to find out whether the ulnar collateral is adequately supplying the form or not, which may otherwise sometimes lead to inadequate ischemic changes in the form. So how it is supplied, all those things I will just skip through. The sample taken correctly or not? Already this has been talked in the first slide. So air bubble has entered. So what will happen to the changes? What changes will happen if air bubble is there?
falsely high
CO2 increased on
Falsely
high
high
PO2 and low
PCO2.
PCO2. Okay, so this is how you must close the needle as soon as you take the sample and put a cap on that. And this steps is necessary to avoid the air entering from the atmosphere or the sample getting spilled out. Okay. Now the correction or the correlation between venous and arterial blood gas sample. Sometimes, you cannot get the arterial sample all the time. So sometimes you force to analyze the venous sample. So what is the correlation between these two samples? Are they mostly equal or do you have some difference?
Some more.
Venous sample will be more acidotic and it will have high lactate level than the arterial.
Lactate level, yes.
And
Venous
CO2
gases are
also more
widely
than
used
5
in
CO2.
emergency setting in preference to serial setting. And correlation is pH, there is a good correlation, more or less good correlation. And the difference is only 0.035. PCO2 with correlation in normocapnia, but it is not a good reliable parameter in severe shock. And the correlation dissociates in hypercapnia also. Values correlate poorly when the PCO2 is more than 45. And bicarbonate, there is a good correlation. Mean difference is only 1.4. Lactate dissociation above 2 millimeter will be there. And base excess good correlation, mean difference is 0.8. So for most of the things except PCO2 in shock, it is if you can't get an arterial sample, there is no harm in taking a venous blood sample and analyzing in emergency situation. And that is the purpose of this particular slide. Now we go to the values and interpretation. This is the first case scenario. pH is 7.56, PaCO2 20, bicarb 20. What is your interpretation?
Respiratory alkalosis.
Respiratory alkalosis. Acute or chronic? Compensated, uncompensated. That also have to be included. Okay. Respiratory alkalosis, it is partially compensated. Okay. Patient has a low PCO2. Why it is partially compensated?
pH is in return to normal.
It is not returned to normal, number one. What about bicarb?
Expected change in the bicarb.
That also has to be calculated and see whether the bicarb is correctly reduced or not. Okay. To make up or to correct that. Now the next condition is pH 7.23, PaCO2 37, bicarb 18.
Metabolic acidosis.
Primary metabolic acidosis with, is it a compensation adequate?
No, sir.
So uncompensated.
Compensate.
So PCO2 is still 37. It should have been very low. Isn't it? Calculating the expected PCO2 should be quite low. So it is a primary metabolic acidosis because bicarb is low and pH is low. And because there is no compensatory washout of CO2, it is uncompensated. Now the next is 7.31, PaCO2 34, bicarb 21. To be little thick. So what is it acidic or alkalotic?
Acidic, sir.
Acidic.
Metabolic acidosis with compensated metabolic.
Partially compensated metabolic acidosis. Okay. So bicarb is not too low, but pH is low, bicarb is also low. For that, the washout is very slight. So it is partially compensated. pH is alkalotic, PaCO2 also alkalotic, bicarb is 24.
Compensated respiratory alkalosis.
Compensated. How do you say compensated?
Partially compensated respiratory alkalosis.
Partial compensation. What should happen to the bicarb in respiratory alkalosis? Should it go up or
It should
it come
increase, sir.
down?
It should go up,
Increase.
sir.
It should decrease.
Alkalosis.
Decrease.
It should decrease. It is normal. Okay. So respiratory alkalosis, which is totally uncompensated. Bicarb is within normal range. It should have gone down. Okay. So be specific in your answer. That is very, very important. pH 7.46, CO2 36, bicarb 32. Metabolic alkalosis, uncompensated. Very good. pH 7.52, PCO2 48, bicarb 28.
Metabolic alkalosis, respiratory compensation.
Metabolic alkalosis. See, pH is 7.52, it's on the alkalotic side. Bicarb is also high, and PCO2 is also being retained. Okay, so it is a metabolic alkalosis partially compensated. Okay, high. 7.25, PaCO2 60, bicarb 27.
Respiratory acidosis with metabolic compensation.
Metabolic partially compensated again. Okay. pH 7.55, PaCO2 47, bicarb 30.
Metabolic
Alkalosis, respiratory compensation.
Alkalosis partially compensated by, right, very good. pH 7.2, PaCO2 49, bicarb 25.
Respiratory acidosis.
Respiratory acidosis uncompensated. Bicarb is not compensated. Okay. pH 7.30.
Metabolic acidosis.
Metabolic acidosis with the partial
Partial compensation. Uncompensated. Okay. pH 7.41. PaCO2 26. Bicarb 17.
respiratory alkalosis.
Respiratory alkalosis pH is normal.
With metabolic
acidosis
compensated
compensated respiratory.
Fully compensated metabolic acidosis. You know, PCO2 is washed out. CO2 is washed out. pH has returned to within normal range. Bicarb is still low. So respiratory alkalosis. I mean, this is respiratory alkalosis fully compensated by decreasing metabolic bicarbonate. Okay, so that is the small catch in that.
Not be metabolic acidosis that is fully compensated, sir.
It is not metabolic compensation. This is metabolic acidosis means you have to have a calculate whether it is the equivalent of expected PCO2 has to be calculated. This is too low than that. For example, bicarb 17, 1.5. How much is that? 25. 25 plus 8, 33. 33 plus 2, 35 should be the PCO2. Isn't it? Whereas PCO2 is 26 here. So this is primarily a respiratory problem where bicarb has come to compensate. pH has returned to normal. Okay. So pH 7.39, PaCO2 48, bicarb 28. pH is within normal limit. PaCO2 is high. Bicarb is slightly elevated than normal. So whether it is primary metabolic or respiratory.
Respiratory acidosis, sir.
Respiratory acidosis fully compensated by elevated bicarb and pH returning to normal. Okay. pH 7.22, PaCO2 49, bicarb 24.
Uncompensated respiratory
acidosis.
Respiratory acidosis uncompensated. pH 7.37, PaCO2 33, bicarb 17.
Metabolic acidosis with partial
Metabolic
compensation.
acidosis fully compensated. Very good. pH 7.22, PaCO2 49, bicarb 28.
Respiratory acidosis
With
uncompensated.
Acidosis partially compensated. Very good. pH 7.42, PaCO2 32, bicarb 18.
Respiratory alkalosis with partial compensation.
respiratory acidosis fall fully compensated. pH has come back to normal. Okay, always remember that pH range 7.35 to 4.5 is always fully compensated. Now some case scenarios. A 75-year-old gentleman living in the community is being assessed for home oxygen therapy. These are the BG values: 7.36. CO2 is that is 10 to 14. It's also low CO2. The CO2 is higher than normal range. ICARB is 31. Is higher. Base excess is 5. Other values are within normal range. What is the interpretation of this ABG?
Fully compensated respiratory acidosis.
Three acidosis.
Respiratory acidosis. Yes.
Okay, this is a compensated respiratory acidosis.
Yes,
This
sir.
does not represent acute pathology. Rather reflects a compensation for chronic respiratory acidosis secondary to COPD. So note this is an acidosis, not an ischemia. P is normal, but only due to compensatory mechanism, that is high bicarbonate. Right. So now what should you do for this patient? Does he need long-term oxygen therapy home or not? Of course, we'll skip this a little bit faster. How do you provide long-term oxygen therapy at home?
Oxygen concentrator.
In
With help.
concentration. So the second case scenario is a 64-year-old gentleman with a history of COPD presents with worsening shortness of breath and increased sputum production. pH is on the acidotic side. CO2 is low. The CO2 is high. Bicarb is also high. Basis is +4. Other values are normal. So what is the interpretation?
Uncompensated respiratory acidosis.
He has a history of COPD.
Acute respiratory acidosis.
Acute on chronic. Okay. So you can see bicarb is
Yes, sir.
chronically elevated in this patient because of his COPD. And he is in acute respiratory acidosis now. And so this is a acute on chronic. So this is a type 2 respiratory failure. Bicarb is raised in this patient despite the abnormal pH. With the above history, it is likely to represent an acute on chronic respiratory acidosis. Okay. So how much oxygen can be given for this man? Because he is also having low PO2.
Have to maintain the PO2
Saturation
saturation between
Very guarded
82 to
92.
94.
You have to give a oxygen in a very guarded fashion because his respiratory drive is mainly because of the hypoxemia. Okay. So oxygen administration is complicated. 100% oxygen makes this patient decreasing respiratory drive and worsening hypoxia and hypercapnia. So you have to give not more than 40% oxygen to these patients. Okay, that is a very important thing. 21-year-old man diagnosed as Hashimoto's thyroiditis had vomiting 1 week back, and its values are pH 7.31 acidotic, CO2 39 normal, CO2 39, bicarb is 19, excess is -7, sodium 108, potassium 6.1, glucose 72, chloride 72, glucose 3.3. So, what are the analysis? First pH,
Metabolic acidosis.
Metabolic acidosis.
metabolic acidosis. Is it fully compensated or not?
Not compensated.
Not compensated.
So pH is low. CO2 compensation it will be 38. So it's okay. Like anion gap, here it is 17. So raised anion gap acidosis. Immediately check delta gap. Change in Ag by change in bicarbonate. So 17 minus 12 is 24 minus 19. This one which is a pure Ag acidosis, anion gap acidosis. The value that we saw earlier. Okay. Both sodium is low and potassium is high, so likely to be Addison's disease. Okay. Potassium is also high, sodium is low. 32-year-old man presents to the emergency department having been found collapsed by his girlfriend. So pH is 7.25, acidotic. CO2 is normal. PCO2 is low. Bicarb is low. And basis is -5. Potassium 4.5. Sodium 35. Chloride 100.
Metabolic acidosis.
Severe metabolic acidosis. Bicarb is so low and pH is also low. For that, there is a washout of CO2. Okay. So it is the anion gap in this case. Will you take both sodium and potassium for calculation, or only sodium and the bicarb and chloride for calculation?
Both sodium, potassium.
Some authors take both sodium and potassium and chloride bicarb. So that will come equal to 8.5 with the anion gap. Normal range is 7 to 16, but 12 is the ideal one. Either way, there is a raised anion gap. Metabolic acidosis is there. What are the causes of metabolic acidosis with raised anion gap? Only some theory.
It is mud piles, methanol,
Methanol
Yeah.
poisoning.
Uremic
Mud piles.
acidosis.
Okay. Traditional mnemonic for metabolic acidosis with raised anion gap. Remember the mud piles. Ethanol, uremia, diabetic ketoacidosis, propylene glycol, isoniazid, lactate, ethylene glycol, and salicylates. Okay. So these are all the conditions that we have. 67-year-old man with history of peptic ulcer disease presents with persistent vomiting, which is on the alkalotic side. CO2 is normal, PCO2 is normal, bicarb is 31, and basis is +5.
Metabolic
Alkalosis.
Pure metabolic alkalosis. So, this is a metabolic alkalemia. Differential diagnosis of metabolic alkalosis are persistent vomiting. So he is vomiting all the acid content, like hydrochloric acid. And other conditions are hyperaldosteronism or diuretic use and milk alkali syndrome and massive transfusion. Okay, these are all the things which can lead to metabolic alkalosis. A 17-year-old girl presents to emergency after an argument with her boyfriend. She says she took some lot of tablets, and ABG taken shows a normal pH or slightly alkalotic pH. CO2 is normal. PCO2 is slightly low. Bicarb is normal. Basis is 0.1. A few hours later, she says she feels increasingly unwell and complaining of ringing in the ears. So when the ABG is repeated, it has become severely acidotic. CO2 is low, normal. PCO2 remains slightly decreased. Bicarb has grossly decreased. There is a very severe negative phase deficit. Okay. So, what is the likely diagnosis of this case?
Aspirin overdose, sir.
Paracetamol poisoning.
Excellent. This is classic picture of aspirin overdose. It's an initial respiratory alkalosis due to central respiratory stimulation. Later, it is a stage of metabolic acidosis along with respiratory alkalosis as a result of direct effect of metabolic calcium of salicylic acid. What are the features of aspirin overdose?
Tinnitus,
Hmm.
hot flashes,
Yeah. Aspiration, hyperventilation, sweating, nausea, vomiting, epigastric pain, tinnitus, deafness, very rarely ARDS and hypoglycemia. What investigations are needed if there is a suspected aspirin overdose?
Acute kidney injury, sir.
LFTs.
Salicylate concentration, paracetamol levels can be checked. ABG, urea and electrolytes to rule out renal failure. Chest X-ray, if the saturations are decreasing, and any restriction of ARDS due to non-cardiogenic pulmonary edema. How is aspirin overdose managed?
So symptomatic management only, sir.
Symptomatic. ABCDE supportive care. Gastric lavage within 1 hour. Activated charcoal can be given. Electrolyte abnormalities have to be corrected. Alkalinize the urine. Okay, by giving 225 ml of 8.4 bicarbonate solution over 1 hour. Ensure the urine pH is always on the alkaline side. Bicarbonate will worsen any pre-existing hypokalemia. So, what's the level of potassium? Additional boluses of bicarbonate to maintain alkaline resistance. Monitor urea and electrolyte. In severe cases, plasma concentrations, you have to go for hemodialysis. These are all the treatment of aspirin overdose. A normally fit 11-year-old boy presents with diarrhea and vomiting. He is complaining of non-specific abdominal pain. The venous blood sample has been taken. It shows a pH of 7.12, CO2 normal, CO2 slightly low, bicarb grossly low. Base deficit is also very high. Lactate is 4, potassium is 5.5, and glucose is 22 millimoles. Other values are within normal range. What is the interpretation? What is very obvious in this?
Hypoglycemia, metabolic acidosis,
Acidosis.
hypoglycemia.
Metabolic acidosis, and potassium, glucose is also very, very high. Lactate is also high.
High.
And he is 11-year-old boy. He complains of non-specific abdominal pain.
Type PK, diabetic keto.
So diabetic ketoacidosis. So patient may be a insulin-dependent diabetic patient, juvenile diabetic. Okay. So how do you manage this patient?
Sir, hydration and insulin
Normal
infusion
management for any
respect
management,
to potassium.
station, insulin administration, and potassium level. Okay. That's the basic thing. Viva, you can just answer in bullet points. You simply tell the important things, not necessary to say in full sentences on. A 22-year-old lady with a known history of asthma presents to the emergency department with difficulty in breathing. She is on 15 liters of oxygen supplementation. The ABG is taken. pH is on the alkalotic side. CO2 is just normal. CO2 slightly low. Bicarb is within normal range. No base excess. After initial treatment, the nurse calls you to review the patient. Nurse says that although the patient's respiratory rate has come down slightly, he is looking more unwell. Again, ABG is repeated. Now pH has become normal. CO2 slightly low. PCO2 has become normal. Bicarb is 2 normal. 2. Other values are normal. How do you manage this patient? Now the repeat ABG shows almost normal values, but
No.
patient is clinically sick. Why?
We have to reduce the
O2 oxygen.
O2. Patient has asthma, ongoing difficulty, the rising CO2. It's extremely worrying sign as the patient shows tiring. So she becomes tired and she requires a dependency area. Okay? So don't be just carried away because all the ABG values are within normal range. Look at the clinical picture of the patient. That means they are tiring because of the effort in respiration. A 62-year-old woman, a history of diabetes, long smoking history, presents to the emergency department. There is a lot of crackles or ralphs in the And marked ankle edema is also there. ABG acidotic, CO2 low, CO2 high, bicarb low, base excess negative 8. This is the diagnosis.
Yes.
Metabolic
Metabolic and
metabolic acidosis and
bicarb is
not
also low.
compensate.
Combined metabolic and
also is
respiratory
high.
acidosis.
It is a combined disorder. So both low pH, low bicarb and PCO2 high is a picture of mixed respiratory and metabolic acidosis. So given the history of diabetes, ankle swelling, renal failure is the underlying or unifying diagnosis with pulmonary edema, contributing to respiratory acidosis, while the failure to clear acid causes metabolic acidosis. So this is a mixed disorder. Okay. So sometimes you may get a case like this. Now, the 56-year-old man presents with anorexia and unremitting vomiting for 4 years. Results of ABG, bicarb 18, PaCO2 30, and pH 7.4. The biochemistry profile is showing sodium 130, bicarb 18. And what is this acid-base disturbance and what is this anion gap?
Compensated metabolic acidosis.
This is a metabolic acidosis with a base deficit of 7. Okay. With a satisfactory respiratory compensation for the acidemia. Okay. Because the pH is within normal range. And so Winter's formula, if you use, you get the exact PCO2 value. Okay. The anion gap is 23. So his base deficit is smaller than his anion gap. His bicarb is 18. So so he has had feeding metabolic alkalosis from 4 days of vomiting, acid-rich gastric contents, he might have started to have a higher bicarbonate concentration before starvation ketosis sets in, because he has not been eating. So his normal pH, despite the elevated anion gap acidosis and compensated respiratory alkalosis, indicates there is a initial metabolic alkalosis followed by now the metabolic. So the 3 disorders are there. Anion gap acidosis is there, respiratory alkalosis is there, and metabolic alkalosis in the initial stage. So this is a triple disorder or a complex disorder. So from the very simple thing, gradually we have now graduated to very complex disorders. So 2 patients, both in respiratory distress, present to your hospital. We have only a single ventilator available. Each has a history of emphysema, and each wants everything possible done to them. Now the results of ABG testing of the first patient shows PaO2 68, PaCO2 58, bicarb 22. The results of the second patient, PaO2 59, comparatively lower than the first one, PaCO2 more than the first patient, bicarb is 38, that is more than the first patient. All else being equal and based purely on ABG analysis, which patient should get the ventilator?
First patient, sir.
Why?
Second patient has compensation with increase in the bicarb.
Bicarb was already very high because he is a known COPD. Both of them are known COPD patients. And so he has already have a good compensation. So the first patient clearly has acute respiratory acidosis. PaCO2 is 18 millimeter greater than normal, that is 58. Every 1 millimeter rise in carbon dioxide should increase the bicarbonate by 0.4 milliequivalent. And that actually increases should be 31.2, whereas his bicarbonate is only 22. Okay. So since his bicarbonate is only 22, he is in acute respiratory acidosis without any compensation. The second patient has a even greater respiratory acidosis, more than the first patient. But using the same rule, he should have a bicarb of 38, which he is having exactly. So this patient is a metabolic response is chronic hypercapnia. So hence the first patient needs the ventilator more than the second patient. Okay? That is how it is taken. Lastly, after all these discussions, what is two-word approach to pH? How does it differ from Henderson-Hasselbalch approach? And who is two-word? The last we know near this because sometimes you do extremely well in analyzing ABG and other things. Then we may be asked about what is two-word approach to the pH.
It is
Idea?
ion difference.
So Henderson-Hasselbalch is a comparison between bicarbonate and carbon dioxide. That is what we saw. pH is equal to bicarbonate and carbon dioxide balancing. But two-word what we said did was, he is a Canadian physiologist, Peter Stewart, and his principles are what is called electroneutrality. That is, the positive and the negatively charged ions should be equal in number. So electroneutrality has to be maintained. For that, you can do what is called mass conservation. The amount of each component remains constant unless some of that substance is added or removed, either physically or by participating in a chemical reaction. So Henderson-Hasselbalch compared CO2 with bicarbonate, whereas Stewart hypothesis says it has taken carbon dioxide to consideration. Plus, there is a strong ion difference between the strong cations and strong anions. And there is a third component called total weak acid, that is albumin and phosphate also. So these three things are taken into account, unlike the Henderson-Hasselbalch, only two things are taken into account. So this much of simplified concept or knowledge about Stewart is more than enough. So examiners, in case they ask you about it, please remember these 2 points: electroneutrality, mass conservation. That is, things have to be replaced or removed either physically or chemically to maintain this equality. And the three components of Stewart approach is CO2, SID, and ATO. Okay. So Stewart approach shows that pH is not simply determined by hydrogen and bicarbonate as in Henderson-Hasselbalch, but involves interaction of other variables, three of which are independent variables that control acidity. So that is the end of ABG. Any questions? Any doubts? Any other suggestions?
No, sir.
No. Was it useful? Do you think it was?
Yes, sir.
Yes,